Hi, and welcome back. Lisa here. We are so excited to bring you this episode, but we do want to offer a content warning. In this episode, Dr. Ayers and Dr. Poullos discuss some things that may be difficult for the audience, including how ableism impacts patients and how at times ableism can lead to things like coerced abortion, sterilization, and even death. We encourage our audience members to engage with this episode in a manner that feels right for them or to skip the episode altogether. Thank you, and on to the show.
Doctors with disabilities exist in small but impactful numbers. How do they navigate their journey? What are the challenges? What are the benefits to patients and to their peers? And what can we learn from their experiences? Join us as we explore the stories of doctors, PAs, nurses, OTs, PTs, pharmacists, dentists, and other health professionals with disabilities. We'll also be interviewing the researchers and policymakers that drive medicine forward towards real equity and inclusion. I am Peter Poullos, and I am thrilled to bring you the Docs with Disabilities podcast.
Hello and welcome back to the Docs with Disabilities podcast. Today we are joined by disability researcher and Associate Director of the University of Cincinnati University Center for Excellence in Developmental Disabilities, Dr. Kara Ayers. In this episode, Dr. Poullos and Dr. Ayers discuss advocacy work, interprofessional collaboration, and the language we use when describing marginalized communities. We begin with an introduction by Dr. Ayers and a discussion about the importance of mentorship in her career as a disability advocate.
I'm an associate professor at Cincinnati Children's Hospital Medical Center. I'm trained as a psychologist. I don't practice clinically right now, and I focus on research, training, and advocacy at a University Center for Excellence in Developmental Disabilities, UCED. I'm at the University of Cincinnati, UCED. Our network is called the Association of University Centers for Disabilities. So that's made up of UCEDs across the country and the territories.
How did you become interested in disability research and advocacy?
I have osteogenesis imperfecta. It's a brittle bone condition. And so much of the research is focused only on the medical aspects. And I knew from growing up with OI and also being a part of the OI community that there were many other aspects of our disability that I was interested in, not only deficits either. I was interested in resilience and coping. And so that was my dissertation focus, but I really wasn't aware of career opportunities related to disability research, even in my PhD program. So that's something that drives me now with my trainees and mentees is I want people to be aware of the full range. I'm so glad that I found those really early in my career, but in training, I very much envisioned more of a traditional clinical path for myself, which would have meant that I wouldn't have been able to do some of the things that, I'm passionate about. And also, to be honest, it wouldn't have been the best match for my disability. My current role allows me some flexibility. So when I have pain or if I've had a fracture, largely still able to be flexible and still work, which at times has been really important to my recovery as well.
Yeah, I guess we have that in common. That's part of the reason I decided to stay in academics as a radiologist is,
Yeah.
working clinically 60 or 70% of the time is a lot better than 100.
Yep.
Flexibility and the ability to do other things and pursue other interests is really important also. So I can totally identify with that. You actually touched on my next two questions. One of them was that I know that you're interested in mentorship as a piece of career development. And I was wondering who mentored you and how did they make a difference in your career?
Oh gosh, I've been fortunate to have so many incredible mentors. One of my first disability advocacy mentors that stands out to me is Andy Imperato. He's currently the director of California Disability Rights. Andy led our network for a bit as well a few years ago. I first was mentored by Andy as a teenager. Right after I graduated from high school, I got accepted to a program that taught me about disability rights and brought youth with disabilities from around the country to DC for a couple weeks out of a few summers in a row while we were in college. And it was just a pivotal moment for me to realize that I could have a voice in policy and government and also to learn the history of my community. So it really changed the trajectory for me in terms of the way not only I viewed disability, but myself and what I wanted to do with my career. And so I'm really fortunate that I met him at that early phase, and then I'm still able to learn from him. I've had so many other powerful mentors. I was fortunate to have a psychologist with a disability that was part of my supervision team during my internship year, Dr. Julie Williams. There's just so many. I get nervous naming people because I don't want to leave people out, but I'm really fortunate to be mentored by other disabled people, which is not always the case for people.
No, I'd say it's more commonly not the case. People feel very much alone and on their own out there. So that's really lucky. And small world, I actually know Andy. I met him a couple of years ago when I started doing this work, and I send a lot of people to him who are experiencing like discrimination in the workplace.
Mm-hmm.
Been an incredible resource in that regard.
Yeah.
So what do you think makes a good mentor?
I think mentorship can look as different as any, dyad or pairing can be. So there's no one way to be a mentor. I think it's getting to know someone. That rapport piece is important. By no means, a therapist or in a therapeutic relationship with my mentees, but I have appreciated parts of my training that allowed me to, actively listen, to allow people to kind of find their own path without pushing them. So guiding and pushing, I think, are different things. And also to allow yourself that, to be surprised by somebody's path where you think someone might go or want to go or would be great at going, may be different for a wide range of reasons. And so I think that active listening piece is important. I also try to be a connector. So I try to connect mentees to resources that might interest them, readings, other people, peers. Sometimes it feels weird for me even to classify them as mentees because I don't so much in our relationships feel like it's very hierarchical. I gain a lot from them as well. So while I try to be very aware of power structures that are in place, I don't feel like that it's like a top-down process.
Yeah. Our mentorship program is called a mutual mentorship program and is also non-hierarchical.
Hmm.
Like recognizing that disability knowledge doesn't really correlate with your academic rank.
Right.
I could be a full professor who became ill a year ago and not
Hmm.
know much, and somebody who's a pre-med would have been disabled their whole life and know a lot more. So yeah, I learn a lot from my mentees.
I think we're seeing the benefits of greater opportunities for young people with disabilities, greater inclusion across more education programs. And we're seeing the proliferation of just more opportunities to be a part of your community, whether it be with sports or with some other extracurriculars. We're seeing that for more kids with disabilities, and that's a good thing.
For Dr. Ayers, advocating for individuals with developmental disabilities has become an integral part of her career. Let's hear about the amazing work she has done with the Leadership Education in Neurodevelopmental and Related Disabilities program.
This ties in directly to this paper that I read, Fostering Disability Advocates, a Framework for Training Future Leaders Through Interprofessional Education. You've touched on a little bit of this already, but so the name of this program is LEND, Leadership Education in Neurodevelopmental and Related Disabilities. Did you start that program?
The program has been around for a few decades. It's an interdisciplinary training that is federally funded. it includes training on autism, but as the name states, other developmental disabilities as well. And our definition of developmental disabilities comes from the Developmental Disabilities Act. So it's fairly broad, meaning people who acquire their disabilities before the age of 21, and that it impacts activities of daily living. So depending on how people kind of self-classify, it includes a large number of people who acquire their disabilities before the age of 21 at least. So this training program brings together multiple disciplines. I think right now we have around 16 disciplines in our program and only about 25 trainees. So you've got a lot of variability. So you've got physical therapy, occupational therapy, audiology, psychology, down the list. But we also have family specialists that are part of the program, meaning family members of people with disabilities who want to hone their advocacy skills, as well as advocacy trainees who are people with disabilities. I started as a faculty member at our LEND program around 10 years ago. When I started, I had a minimal role, and then now I'm the advocacy faculty for our LEND program. And so that means that I work with not only our advocacy trainee, but like today we're having mock legislative visits with the trainees. It'll be really fun. I get to pretend to be a senator and they come in and make their pitch, and I'm pretty nice to them. I do not do what some staffers have done when I've visited the Hill to talk to them about issues, which is like be totally distracted. And I even had one staffer clip his fingernails while I was telling him about my important disability issue.
Oh no.
So it's a really fun program that, it's a year long. So they emerge with a lot of disability related knowledge. And we really try to break that medical model that has been so driven into them during the rest of their training.
Yeah, wow. Well, I was very impressed by the organization of the program.
For people with disabilities, collaboration with occupational therapists, psychologists, social workers, and other professionals can play a critical role in receiving the proper accommodations. Let's hear from Dr. Ayers about the importance of interprofessional collaboration in serving disabled populations.
One thing that people have been talking more about lately is in interprofessional collaborations, and that's emphasized in the paper. Why do you think that's important?
Well, we can, learn so much from each other's disciplines. And I think that it's also this myriad of different strengths and limitations that we have that if we pool them can really benefit people with disabilities. So one of the issues that I work closely on is parenting with a disability. And we're often limited by what supports we can provide to people because in the United States, parenting is not considered an activity of daily living. I have 3 kids and I can assure you it is definitely an activity of my daily living. But in Canada, it is considered an ADL. And so because of that, it's factored into assessments. It can be used for goals. Whereas in the United States, people have to find workarounds for that. But I have found, as I learned from my colleagues and my trainees who are occupational therapists, that they have some different tools and strategies that really align well with supporting parents with disabilities. I've also benefited from working with other psychologists and social workers to help parents who may have intellectual disabilities or psychiatric disabilities, building things like social stories about what to expect when you go to your child's pediatrician visit so that you're able to prepare for that and it won't be overwhelming, more overwhelming than I guess it is for all of us. But so bringing together all of our skill sets can benefit everyone, not just people with disabilities.
In 2021, a paper titled Rethinking Individual Autonomy in Medical Decision-Making for Young Adults Reliant on Caregiver Support, a case report analysis was published in the Journal of Clinical Ethics. In this paper, the author outlines a case in which a physically disabled 26-year-old woman is encouraged to terminate a desired pregnancy by her parents and healthcare workers. In this next section, we will hear from Dr. Ayers about her response to the authors of this journal article.
Yeah, I was really interested in your work on disabled parenting. being a disabled parent myself. I was reading another article of yours, Rethinking Systemic Ableism, a response to Zagouras, Ellick, and Alicio. So can you tell us more about the case and why you felt compelled to write a response to it?
I was shocked that not only the authors had published this, but this went through the whole editorial process, peer review. And so the young woman's name in the article is Julia. She's 26. I believe it's described that she has a neuromuscular condition that means that she relies on caregivers for all of her self-care. She becomes pregnant with her boyfriend. The couple desires the child. The parents do not, and tell her that if she does not terminate the pregnancy, that they will place her in a nursing home. So they then go to the hospital to her care, what's described as her care team, and the care team aligns with the parents and in an interesting conceptualization of the case decides that although she's 26 that it's more similar to a adolescent pregnancy because she has not had the same social opportunities that a typical adolescent has had, which largely are because she has a disability and has been reliant on care and has been, segregated from these opportunities. So I found that conceptualization odd because it would not be appropriate to coerce an adolescent either. But finally, the other interesting piece of their view on this case was that they saw it as a feminist conceptualization of the case because they considered caregiving outside of the individual making the decision, the autonomy of the individual with the decision, which to me was just not in line with a feminist view because in essence they objectified Julia as literally a vessel for the caregiver's unwanted pregnancy. Julia did terminate the pregnancy, after both her care team and her parents aligned to threaten that if she did not, she would be placed in an institution. So it was a very depressing case to read, very personally triggering as a disabled woman who's been pregnant, as a disabled person who's relied on caregiving sometimes. So I think in some ways I channel my professional advocacy as a coping strategy at times. Like I feel like I have to do something when I see these egregious violations. What I wish I could do is find Julia and let her know that she is not alone in life, but that I feel like she was treated very unfairly by our system. At the end of the day, the system should have been the safeguard for her. They should not have become conspirators with her parents' ableism.
But you also mentioned that this sort of scenario is not uncommon. It might actually be more common that disabled women are encouraged to have abortions than given supportive care during their pregnancy.
Too often we talk about things like coerced abortion or sterilization as if it's in like past tense, and it is not. Our healthcare system unfortunately can be shifty when perpetuating oppression and kind of learns not to use words like sterilization, which raise red flags, but when the system frames it as menstruation management, less red flags are raised. And not to say that that's not a valid course of treatment for some people, but I see it used very frequently without consideration of the obvious repercussions that it also is stifling ability to become pregnant. Just last week, actually, I was part of a online parenting forum in my area, in my neighborhood, because of my three kids, one has a disability. Um, and a parent posted and said, my daughter turns 18 next month. Her daughter has an intellectual disability. And she said, I really need to get her a hysterectomy, but her doctor won't do it. And within a few minutes, another parent said, we took my daughter to Dr. XYZ. She didn't ask any questions and it was fine. So through word of mouth, there's this network of sterilization. And so it's very easy to see that it unfortunately continues, especially with threats like institutionalization or refusal to continue caregiving. So it's, yeah, sad.
It just shows how deeply entrenched ableism is in our society and in our psyche.
Exactly. Yeah, sometimes that's referred to as common sense ableism, which is like a ironic twist, not that it's actually common sense, but that people accept it as just as fact or truth. And, I presented Julia's case actually this weekend for the first time in a talk, and an individual waited after I gave the talk, and he wanted to clarify that Julia didn't have an intellectual disability. And so I said, well, this wasn't my direct case, so I can't be sure, but it was not noted that she did. And so this person was like, well, that's good because that would change everything. And I felt compelled, given my work supporting parents with intellectual disabilities and knowing that they can parent. I said, well, people with intellectual disabilities can parent. That's not just my opinion. There's research that supports that. And he disagreed with that. He was pretty adamant. But it was one of those things where it seemed like to him it was common sense.
Let's shift gears as Dr. Poullos and Dr. Ayers explore health equity and how combating ableism benefits both disabled and non-disabled people.
You've also stated that health equity benefits everyone, including people with disabilities, and that ableism harms all of us. So, can you elaborate more on that?
I think sometimes we think of our anti-ableist work as benefiting only people with disabilities, and we really limit its potential when we think about it like that. Much of anti-ableism is about untangling those insidious forms of discrimination in healthcare, like making judgments on value of life or quality of life. Healthcare providers are not good at making estimates of quality of life. We continue to allow those subjective thoughts to direct clinical decision making, and that can harm everybody, whether you have a permanent disability or whether you're acutely injured. It's these assumptions about what others' value of life is. I've heard people describe non disabled people as temporarily able bodied, like tabs. And I get what they're saying in that, if we live long enough, most of us will become disabled. Those of us who already are just kind of have a head start. But I don't know. I don't use that very often because I also worry that it has kind of like a fear approach, like, well, you're not disabled now, but wait till you are. And I don't think that's helpful. But it is worth stating that, as people age, the prevalence of disability among the population increases. And then even beyond that, you have so many close connections. I mean, I think about our family. My husband and I both have disabilities. We're both wheelchair users. And so my daughters who do not have disabilities have very much been impacted by ableism in our community, whether it be in accessible spaces or, judgments that people make about their parents. And most of the time, those things, may result in more of like a headache, more of like an annoying interaction with somebody. But what about when it results in not receiving the health care that one of us needs, in a really life or death moment? The stakes can get high pretty quickly. And if we realize how interdependent we are on each other, we realize that we do not want a healthcare system that's set up to prioritize only certain groups of privileged people.
Yeah, I don't know if you're familiar with Talila Lewis's working definition of ableism. You do not have to be disabled to experience ableism.
Yeah, I really like TL's connection too with racism and eugenics and capitalism and colonialism, kind of recognizing that all of these are rooted together with ableism and that we can't pull up one without also working to pull up the others. And that way of thinking has really shifted for me. My advocacy, I used to ascribe to the idea that every single person should work. And as I looked back in thinking about why I came to that conclusion, I learned more about the capitalist view. Capitalist society wants us all to work for its benefit. It wants us to produce and to reproduce for the benefit of a capitalist society. And so while I want people with disabilities to have as much choice as any to get in that rat race of working and employment, and I still very much advocate for that, I now try to step back and think about like, we want to make sure it is a choice. I think many of us are just kind of pushed in that stream of capitalism and not really thinking about it as a choice. There's so many just examples of discrimination in employment that we need to work on. But TL specifically really got me thinking about capitalism and the way it holds back people with disabilities as well. One thing that I like to connect it to is the disability justice framework of Sins Invalid. And they have 10 principles of disability justice. And one of their principles is interdependence. And I just think it's so much more honest and authentic of how we all live rather than independence, which, as a kid growing up with a disability, that word was the ultimate goal, right? It was like at the top of the mountain, like everybody's trying to get you to be independent. While I appreciate that goal, and I do think that it helped me in many ways, I think about what difference it would have been if my goal would have been interdependence, recognizing that we all rely on each other for some things. None of us live off the grid. We're all getting help. So why is getting help in this way any more stigmatizing than getting help? We have our trash picked up every week. We have different assistance throughout the day that in a non-disabled world, we don't even think about it as help. We just think about it as services.
Another core facet of the disability justice principles that we were talking about is intersectionality. I'd love for you to talk about your new Center for Disability Equity and Intersectionality.
Yeah, we are so excited about this work. It'll be a 5-year center, and we have several partners. We have the School of Medicine at Morehouse. We have the Autistic Self-Advocacy Network. We're partnering again with the Maryland USAID at Kennedy Krieger, as well as Georgetown University, their Cultural Competence Center. We will form a community of practice where I really want to bring together both individuals and organizations, and not everyone in the room will have disability as their primary focus. I really want to bring together leaders in anti-racism and anti-sexism and those fighting homophobia and other forms of oppression as kind of adding the disability layer to that. So I'm hoping that we can literally diversify that with this project and we can each learn from each other. So kind of scaling up the interdisciplinary training model that I've seen work so well here in a healthcare setting to look at it in a wider scope. We're going to work on healthcare equity, yes, but also community inclusion and also justice. So a little bit wider of the focus and those stakeholders who will be included. I'm proud of the fact that this project is authentically led by disabled people.
Which is another principle of disability justice, right? Leadership to the most impacted.
Yeah.
The language we use when speaking about marginalized communities can often have downstream impacts. Listen in as Dr. Poullos and Dr. Ayers approach some of the language surrounding disability, including person first versus identity first language, and the use of the term special needs.
I wanted to also touch on the article about disability language. You wrote this article, and I think it came out last year, Disability Language. I'm wondering what prompted you to write that article.
I co-authored that one along with friends and colleagues, Doctors Aaron Andrews and Robin Powell. Each of us individually have all had the unfortunate experience of editors sending us back our bios and telling us to identify with person first language. And we have kindly written them back, educating them about identity first language, letting them know that it was, in fact, an intentional choice for a reason. But we saw the embedded ableism in so many pieces of that, one, correcting a person's own identity, two, censoring this very valid form of language, identity first. You hear people say things like, we have so much work to do. The last thing we need to do is be quibbling about order of words we put in. And we've all felt like that as well. And there's definitely times to, opt out of the language argument. So I think in this article, we tried to capture that these two primary approaches, person first and identity first, are both valid. They both have different histories, different purposes, arguably, but there are a few boundaries that we should consider. One being correcting other people in their preferences, and another being that we as a community have a right to have evolving, changing thoughts about the words that describe us. Sometimes I hear people say, I don't know what to say anymore. It used to be this, and now it's this. I give up, and I find that that's a really closed approach to learning about any marginalized group. We have a right to change our minds, and changing our minds is a good thing, actually. One of my favorite authors is Adam Grant. He wrote a book called Think Again, and I really love the idea of thinking again. Too often I think in our society we criticize it and say that, well, you said this yesterday or last year and now you're flip-flopping, and it's a huge strength to learn more, to reconsider your original view and to change your mind. And in some cases that's what we're seeing play out in real time. As people think differently about disability, they're going to use different words to describe it.
Yeah. What a coincidence. I'm reading that book right now.
Oh, wow, I love it. It's one of my favorites.
Yeah, it's
I hope you like
excellent.
it too.
Yeah, I
Yeah.
think that's like a very important trait, is the ability to reconsider your positions and not be so rigid.
And it's hard. We want to dig in our feet and and claim it as this is what I think. I personally use identity first language if I'm identifying myself. I say I'm a disabled woman, but I actually recognize that my son, who's 15 and figuring out his place in the world, I actually would not just say he's a disabled young man, or I would look to him to see how he wants to identify. And in many cases, right now in his life, I don't think he would actually include that in the first sentence of his identity, and that's okay. I'm a big follower of Brene Brown, and she's talks a lot about, impact matters more than intention. And we hear that so much in the disability world. Well, they meant well. They didn't mean any harm. But, context matters as well. I think about growing up in Kentucky, and people sometimes refer to me as that crippled girl. And I think it contributes often to where many in the disability community have been able to like reclaim crippled. But for me, it will just never quite have that, because like I'm fully aware that those people who called me that were not like embracing some like advanced cultural identity of being crippled. It was not that meaning to them. So, people's personal history matters as well. And yeah, I have friends that use it to refer to themselves, and that's fine with me. I don't connect to it.
In that article about language, and this is a quote, by separating the person from the identity, person first language implicitly indicates that disability is an undesirable characteristic. Thus, first person language may have inadvertently overcorrected and further stigmatized disability. And this is such a fear for me in my work in education and advocacy, that I could be, through my efforts, being inadvertently making things worse. I mean, can you tell me about why person first language possibly backfired?
People want very clear guidelines, and person first language, especially when we're training, it often comes with like a do and don't table, literally. Do say this, don't say this. And so people find comfort in getting those clear guidelines. But clear guidelines can, first of all, vary for people. I think the most salient example of how we can inadvertently send this stigmatizing message is when you hear people say, she's a person who happens to have a disability. And then you think about if you would say that with any other piece of identity, like Mary's a person who happens to be a woman. It's almost emphasizing like, but it doesn't matter. Don't think differently of Mary. She happens to have a disability. Person first language has often historically come this whole suitcase of, we use this language because a person's not defined by their disability. Well, what does that mean, not defined by their disability? I mean, for most people, disability is a major part of their everyday life. So it almost sends this message of, you have to overcome, you have to be as if you weren't disabled. So I think it's kind of the suitcases that we pack along with person first language. And you don't always have to pack those suitcases. So not to not to let you off the hook, but I I have an inkling you don't pack all those suitcases. And I often model person first language with my trainees because it's a good neutral ground for a wide general audience. And I also think about that many parents of kids with disabilities aren't even to a place of saying disability yet. They're still saying something like special needs. And so, for identity purposes, I would rather get them the next step, which is saying my son has a disability, than trying to make that leap and saying your son is disabled. I think special needs is more stigmatizing. So I often model person first language when I'm teaching my trainees how to talk about disability.
In this next section, Dr. Poullos and Dr. Ayers discuss the important role the disabled community plays in supporting disabled individuals.
We also write in the article that those who both personally identify as disabled and feel connected to the larger disability community experience improved well-being, self-esteem, and quality of life across a wide range of disabilities. How so?
So that is based on research. Kathleen Bogart is one researcher that comes to mind that has shown improvements in connecting to identity as a disabled or a person with a disability. I think it, it has to do with many factors. When you're a member of a marginalized group, there can be that sense of isolation. As disabled people, we have this unique experience sometimes from other cultural minorities in that we may be the only person with that identity in our family. In many other marginalized identities, even if you feel alone in your community, you often are reflected in other family members that you have. Whereas for us, that may not be the case. So recognizing a shared identity with others comes with the benefits, including self-esteem and quality of life. You can also learn from others. So that peer-to-peer learning, it can be invaluable, whether it be literally tasks of every day, how you manage to do laundry as a wheelchair user or whatever, or how to cope with the public's ableist response to you. And it opens up a wide range of doors when people identify as disabled.
Yeah, I couldn't agree more. This has been a journey that I have undertaken with my colleagues here at Stanford. Many of us did not identify as disabled before we started our group, and now we're all embracing it as a matter of disability pride and community. I think it's made a difference.
Now let's hear how Dr. Ayers' work led to a presentation at the White House and what advice Dr. Ayers has for disabled individuals.
You got invited to speak before a task force, right, by President Biden to address COVID-19 related health and social inequalities.
Oh,
What was that like?
that was anxiety producing. I think I had 7 to 10 minutes to make my case and recommendations that would ultimately be a part of their final report and then became part of their action plan to address the inequities in the COVID response. So it was worth all the anxiety because it felt like it really mattered. We got many of the things that we asked for. When I say that, I mean we got people working on them. They were not things anybody could magically, fix per se, but I think we all saw from the very start of the pandemic the massive inequities. Many people with disabilities can't social distance when you need somebody to come to your home to get you out of bed or to help with bathing. So we saw so many needs and just glaring examples of gaps in our society. And then, also just the devaluing of the disabled life, which we still see. The pandemic is not over, and we hear things from the collective society like, well, if people are high risk, they should just stay home, or it really only kills people that were already in bad health anyways, which, not only is false, but also shows a real devaluing for disabled life. So similarly, I think I channeled some of my own fears for myself and my family and my loved ones with disabilities into trying to better the situation. So we worked a lot on vaccine access, which in the beginning, resulted in the dashboard that our Center for Dignity created in partnership with Johns Hopkins, their Disability Health Research Center, with Dr. Bonnie Sweener. We had a dashboard that showed people, like, whatever state you lived in, you could look at when your state prioritized the vaccine and even how they defined disability. And we updated that weekly, and we had a team of volunteers. And so California, I remember we were updating it quite frequently as you all went through your various phases of prioritization. So
I mean, it really unveiled so many disparities, right? Not just
mhm,
amongst those with disabilities, but also different racial and ethnic groups and different socioeconomic groups.
mhm,
It really just magnified everything. Yeah, and in fact, you wrote an article, No Body is Expendable, Medical Rationing and Disability Justice during
mhm.
the COVID-19 pandemic. Can you tell me a little bit more?
We reflected back a bit on the early guidance that literally triaged care away from disabled people. If they were to come to an ER, they would potentially not be given, a ventilator if they needed it. We saw that play out, or we heard it play out in some really terrible, heartbreaking audio from Michael Hickson's family, who was a Black man with quadriplegia who had severe COVID, and his family had asked for the medication treatment that was given to other patients in his condition. The doctor was on audio saying that Michael was not a walking, talking person before he got COVID. And so they would not give him the medication because it would not improve his quality of life. And so Michael's wife pointed out that, well, if he dies of COVID, he will not have a life. And the doctor doubled down and said, well, his quality of life would not be any worse. I think this happens often. The unique thing about his case was that we heard it, him literally state that he didn't believe that death was any worse than living with a disability. So this article tried to capture some of that value judgment on disabled lives and tried to point out that we are not expendable or disposable, that our lives have meaning. It feels sad to even think about that we need to write an article with that main point, but there were many, many, and are many, many examples that it's not widely accepted in our healthcare system.
Oh, it's just chilling to think about.
Yeah. Yeah, it is very
Yeah.
heartbreaking. The hospital stood by the emergency room physician who said this. To my knowledge, he didn't even have any minor disciplinary action or any expectations that he receive more training. There were like a number of really sad parts of that case. He died alone because they also had, quote, visitor restrictions at that time, even though he very much would have benefited from a support person, if anything, to advocate for his needs. The hospital determined his case to be medically futile. So he was put into hospice care there in the hospital, and he passed away shortly after alone. He was a father of five, I believe, four or five kids. I keep his story in mind in our work, and just also remembering that I know we're all tired of COVID. I'm very tired of COVID too, but it's not over, and we have to continue to fight and continue to teach people that our lives have value.
Wow. That's a very powerful story. This work is very personal to you in so many ways. A lot of your inspiration for writing these things has been like your emotional response to these very current events. Last question, and we ask this of everybody, is what sort of advice would you give to a disabled person embarking on a career in healthcare or medicine or science?
I would say kind of find your people. It doesn't have to be a large group of people, could be just a few people, but you need people that are going to cheer you on, lift you up, listen, mentor, all of the roles that kind of keep us going. So find those people that you feel those connections with. Maybe it's a shared interest in your field. not everybody with a disability has to pursue disability research. I try to clarify that because I look forward to a day when we disabled people are sprinkled, across all the fields, but I'm focusing on like the science fields and healthcare fields because we don't all want to study disability just because we have disabilities. That's not a prerequisite for working with me or, what I value in a colleague or a professional. But I think for those of us that do, knowing that that's okay and that we were all taught as disabled young people, if we were young people with disabilities, that to achieve success, we would need to overcome our disabilities. And recognizing that if we overcome our disabilities, we leave a huge pile of our strengths behind. So I really encourage them to bring those strengths with you. In reality, you're not leaving your disability behind anyways. So bring it with you with pride, work on that pride. I really love the work by Laura Hershey. She has a poem that talks about practicing pride, and it takes practice. You can't ever stop practicing. Internalized ableism will eat our soul. So practice your pride and find your people, I think would be my advice.
Yeah, that's wonderful advice. Thank you.
Hi, everyone. We hope you've enjoyed this delightful interview between Dr. Poullos and Dr. Kara Ayers. This is Zoe, the co-host and curator of Research and Resource Rounds, a minicast from the Docs with Disabilities initiative. Our third episode features work by Dr. Ayers that I think you will enjoy. This episode discusses her article, co-written with Erin Andrews and Robin Powell, titled The Evolution of Disability Language, Choosing Terms to Describe Disability. We've included this as a bonus on this podcast. So take a listen or review the transcript.
Thank you to our guest, Dr. Kara Ayers, for sharing your wisdom and expertise with us today. We are so grateful for your insight on mentorship, interprofessional collaboration, and disability language. To our audience, thank you so much for joining us for this episode. We hope you subscribe to our podcast and tune in next time. This podcast is a production of the Docs with Disabilities Initiative and is supported in part by the University of Michigan Medical School Department of Family Medicine M-Disability Initiative, the Stanford Medicine Alliance for Disability Inclusion and Equity, and the Ford Foundation. The opinions on this podcast do not necessarily reflect those of the hosts, their respective institutions, or the funders. This podcast is released under Creative Commons Attribution Non-Commercial Non-Derivative License. This episode was produced by Lisa Meeks and Gabe Abrams with support from our audio editor, Jacob Feeman.